Yes. Okay.
¿Comenzamos?
Sí.
Ok.
Sí, por favor.
Buenos días con todos. Es un gusto estar en este webinar. Creo que el contexto actual de la epidemia de coronavirus nos lleva a buscar opciones diferentes de tratamiento que nos puedan brindar unos mejores resultados con nuestros pacientes. Nosotros acá en Perú tenemos problemas cuando vemos nuestros pacientes que entran a la fase aguda de la enfermedad con un compromiso severo, y lo que nosotros intentamos es, en la medida de lo posible, evitar que lleguen a ventilación mecánica, y si los pacientes llegan a ventilación mecánica van a tener que sacarlos más rápido del ventilador y por lo tanto que tengan un curso menos intenso. Existen muchas estrategias en este nivel, y una de estas estrategias es la terapia con Cytosorb en estos pacientes agudamente enfermos. En esta oportunidad estamos con el profesor, el doctor Solf Molnar, que es un médico con especialidad en anestesia y terapia intensiva y que se desempeña como jefe del departamento de anestesiología y terapia intensiva de la Universidad de ESECS en Hungría. Tiene una amplia serie de publicaciones y yo creo que tiene un amplio currículo de asistencia a eventos internacionales. A nosotros nos interesó mucho cuando en algún momento alguno de nuestros médicos nos comentó las posibilidades de la terapia, de este tipo de terapias, porque creemos que nos pueden brindar algunas alternativas para el mejor manejo de los pacientes. Sin nada más preámbulo, los dejo a ustedes con el profesor Sol Molnar.
Well, thank you very much, Walter, and thank you very much for the organizers to invite me to this meeting. I'm very happy to be with you. I've never been to Peru. I've been to several South American countries over the last 10, 15 years, but never to Peru. So I am really looking forward to the first occasion. Then we can eventually meet again after all the pandemic will be over. So I was asked to talk about the role of Cytosorb in COVID-19 patients. And before we jump into the details, let me just give you a brief overview of cytokine absorption. And this is a recent paper in which we published something which is a philosophical approach of what does it mean that we are healthy. And to be healthy means that the antagonistic forces in our body are in balance. And this is exactly what is depicted by the yin-yang symbol. I'm sure you are all aware of that. And it is not necessarily the balance between the good and evil. It is the balance between the antagonistic forces. And why is it important for us critical care physicians? Because just think about homeostasis. There are two forces, acid and base. These are not bad and good forces. These are equally important forces, and they must be in balance. Otherwise, if this goes out of order, then the patient will end up on the ICU or the emergency unit and will require renal replacement therapy or else. The same holds true for our hemostasis. Pro and anticoagulation are two equally important but antagonistic forces. They must be in a dynamic balance to stop a bleeding if you cut your finger and prevent you from developing a deep vein thrombosis while you are listening to my talk, for example. Oxidants, antioxidants, again, a very important issue because nowadays pharmaceuticals are selling antioxidants like the remedy for eternal life. And this is rubbish, because this is a very fine-tuned system, just like the acid base and the coagulation. And you cannot really intervene by taking antioxidants. No, it doesn't make any sense, because if you eat a lot of antioxidants, you will excrete a lot of antioxidants. So what I'm getting at, that our body is functioning on several assets on a balance. And this holds true also for our inflammatory response. And in this whole COVID and inflammatory response syndrome kind of thing, this is the most important balance, what we have to consider and we have to talk about. Now, this is a very nice paper. Last author is Didier Payen, a good friend of mine, and this is a lovely paper I do recommend you to read. And on this figure, what you can see is the following, that our immune system fundamentally has two components, the innate and the adaptive. Now, let's call these, to following this balance type of thing, the pro-inflammatory and the anti-inflammatory forces. And these are in balance. When you are healthy and you feel all right, then there is always a continuous alert of the immune system that protects you from any insult from the environment. Our skin is a perfect protection. However, we are open to the environment via our eyes, mouth, nose, and every orifice. And on these gates, guarding the borders type of thing, our immune system is on a bit of an elevated alert. And when we are ill, we become ill because via these borders, just like the COVID-19 enters our respiratory tract, our immune system changes gear. And this is what you can see on this figure. And this is very important what you see here, that both the pro-inflammatory and the anti-inflammatory forces increase their activity. Why is it? Why is it so? What is the rationale of this? Well, the pro-inflammation has the role to kill the invaders. But this is also true for non-infectious insults. If you have a tissue trauma, you fall off your bicycle, you're hit by a car, you hit your finger with a hammer, then there will be dead tissues, and dead tissues must be cleared off. So this is pro-inflammation. These forces will clear the dead tissue and they will kill the invading pathogens. The role of anti-inflammation to keep this war against the malicious cells, against the pathogenic cells under control. And this is why you can see this type of increasing activity type of trajectory. And if you are healthy, even when you feel that you are ill, after a few days, 5-6 days, these will return to normal and you will recover. And we all experience that during our lives. Our injuries got healed. We had high fever, aches and pains during a flu epidemic, but then returned to work after a few days. If are healthy, our immune system can deal with this. Now, the problem with the critically ill patients is the following, that this nicely controlled immune response, host response, goes out of control. And at the early phase, pro-inflammation overwhelms anti-inflammation. And these patients can die due to early, we called it in the previous years, like fulminant septic shock. And the rationale is that if we can attenuate this burden of hyperinflammation, you can call it cytokine storm, with removing the overwhelming reproduced cytokines, we may, with hemoadsorption, we may improve patient outcome. Well, one of the available and obviously the most studied devices is Cytosorb. The Cytosorb, this is a small cartridge of 300 milliliters in volume, containing millions and millions of small beads. These are biocompatible beads. And these beads, as you can see here, these beads have pores, and these pores can absorb molecules. And the surface where these porous made beads produce is enormous. It's like 4 football pitches. And the size of the pores enables the beads to absorb molecules within this range from something like 10 to 60 kilodalton. So in other words, we have all the cytokines in it, in addition to other molecules, but no albumin, no immunoglobulins, so nothing else, what is also important to protect our body from pathogens and damage-associated molecules. So this is Cytosorb, and how does it work? Well, initially, obviously, the concept was tested in animal experiments, and this is one of the first ones coming from 2008, and the leading scientist is John Callan from Pittsburgh, and he led this study group, and he led the initial research with Cytosorb. And what you can see here on this figure is the following, that the level of tumor necrosis factor alpha, interleukin beta, IL-6, IL-10, they all reduce in the animals, and these animals were made septic by doing a cecal, legal, and puncture. And then they measured all these cytokines over time. And you can see that in the Cytosorb treated animals, these were reduced significantly, while in the non-treated animals, this was not attenuated, and the level of cytokines increased. So there is now animal experiment proven evidence that Cytosorb therapy reduces cytokine levels in blood. Now, how I joined this project is the following, that we did, and this is still one of the first and only paper. Unfortunately, this is only a proof of concept pilot study in which we randomized patients who were in refractory septic shock, and we treated them with Cytosorb or without Cytosorb. So these patients were not on renal replacement therapy. So we did something similar what John Callan's group did with animals. And what we found that regarding vasopressors, patients who were treated with Cytosorb, they had a 70% decrease in noradrenaline requirement, and there was no significant change over time in the control groups. Now, please acknowledge that we only gave one 24-hour treatment to these patients. And then, because we wanted to see if one 24-hour treatment has any effect on the physiological variables. Regarding cytokine removal, well, obviously we were not able to remove all types of cytokines, what you can do in an animal experiment. So we looked at procalcitonin, which is a very prominent and very widely used inflammatory mediator and inflammatory marker. And what we found that there was no change in the control group, but there was a significant change in the treated patients. So we concluded that we translated the results of what John Callan found in the animal experiment into human data. And we have now a very important paper coming from the Netherlands. More than 100 patients were looked at who were treated with Cytosorb, and they were in a propensity score matching special statistical analysis compared to patients who were not treated with Cytosorb. And they performed, it is a complicated statistical method to make the two groups very similar, like severity of illness, organ dysfunction, and so forth. And they found that the mortality was decreased in the Cytosorb group by almost 20%. So this means that if you do Cytosorb, you may improve survival in patients who are in refractory septic shock and require renal replacement therapy. So this is the background of why we entered this COVID era with this idea of treating patients with Cytosorb. And now let's see, what is the indication of Cytosorb in COVID-19 patients? This is an old figure, and this is important. That was published several years ago. I don't even know the time when it was published, but as you can see here, Cytosorb is not a sepsis adjunctive therapy, because it is an adjunctive therapy, it is not a causative therapy. But it's not only for septic patients. You can use it in any hyperinflammatory conditions. And even before the COVID era, you can see that influenza and ARDS was within the indications, possible indications of Cytosorb, because both of these conditions are accompanied by hyperinflammation, cytokine storm. And if you use cytokine removal, then you may just remove these cytokines and you regain balance, regain control. And by doing this, you may help the immune system to take back control in these patients. A bit more specific COVID-19 pathophysiological data. This is a very nice paper by Matthew Tai and co-workers. And when we become infected or we encounter the virus of COVID-19, fortunately, the majority of us will respond in a healthy way. And 80% of those who acquire the virus will get through without any problems, because these immunological mechanisms can prevent us to develop a disease. However, the rest of the patients may develop some sorts of problems, and the most severely ill will develop all the syndromes, what we see in our septic shock patients. And this is all related to cytokine storm, increased permeability, hyperinflammation, vasoplagia, and so forth. And this will lead to severe pulmonary edema and pneumonia, and widespread inflammation and multi-organ system failure. So this paper also recommends that, yes, theoretically, we can intervene with the virus, with the receptors and so forth, but they also depict, and this is an early paper during the middle of the COVID-19 epidemic, that mechanical elimination of cytokines with Cytosorb, removing all the PAMs and DAMs, the pathogen and damage associated molecules, may help patients. And most importantly, they also highlight the fact that controlling the inflammatory response may be as important as targeting the virus. And looking back to my 30 years in intensive care, I can just reassure that even when there is bacterial infection and bacterial sepsis, modulating the inflammatory response may just be as important as targeting the bacteria or the pathogen. And this was recommended very early. This is an article from February by Claudio Ronco, Paolo Navalesi, Jean-Louis Vincent, and they propose that new extracorporeal organ support therapies, including chemoadsorption and hemoperfusion, with new adsorbent cartridges designed to remove cytokines and other circulating mediators, should be considered. And this is a very important statement. And the WHO also, in their classification of treatments, within the life support cluster, they highlight Cytosorb therapy as an important option within the treatment. Now, treating severe COVID-19 patients, why Cytosorb? Why would this be one of the first choices? This is a very recent review, and I have no time to go into this. But this is a lovely paper, again, by Sanders and co-workers. in JAMA, recently published. And there are 7 potential targets where we can interfere with the pathophysiology of COVID-19 infection. And they go through each and every 7 potentials in this article. So please do read the details. May I just draw your attention to the conclusion that no therapies have been shown to be effective to date. And I have some explanation. Of course, it is more or less my personal view in this, but I've been researching inflammatory response for 25 years. And this is my view, what I would like to take you home as a note. Targeting one component of this inflammatory process, let it be IL-6 with tocilizumab, it doesn't make too much sense to me because I've been looking through those 30 years of my career, and regarding septic shock, non-single monoclonal antibody treatment provided any benefit for our patients. What worked in animal experiments never worked in human studies. And possibly, and I started my research career with antioxidants. So we were not targeting IL-6, we were targeting the oxidative materials, the oxygen radicals, and with antioxidants. And this was a wrong move. I now appreciate that, and I acknowledge this. This was a wrong move because you cannot just pinpoint one single element of this huge array of cytokine storm and just target this. It will not change anything. Regarding immunosuppression, and of course, I appreciate all the works done by other researchers regarding giving steroids, and I also use steroids in patients. But by and large, starting steroids at the beginning and attenuating and causing immunosuppression, because when immune response is needed to conquer the disease, to get rid of the invaders, to deal with the hyperinflammatory scenario, I think it is a double-edged sword, to say the least. So it is a controversial issue, even in the literature. However, just taking the edge of the hyperinflammation and just removing those cytokines which are in abundance in the circulation, it may follow some logic. Also we have several case reports, retrospective data, prospective data, some randomized trials indicating that yes, when you do this, the patients will improve their hemodynamic conditions, and we can certainly objectively detect the reduction in inflammatory markers. And this leads us to from pharmacological therapy to extracorporeal cytokine removal. And this is a paper published by people who treated these patients in Beijing. And they say that blood purification therapies have a potential role in the treatment of severe COVID-19 combined with AKI, with acute kidney injury. And they also propose that this is a window of opportunity and especially early application of blood purification. This may be a topic for discussion, a very important issue, this early. What does it mean early? So I am not going into this. And there are societies and even in India, my good friend Yati Mehta, they published, and Yati Mehta is the chairman of extracorporeal therapies in this part of Asia, not just India. And they also propose Cytosorb as an extracorporeal cytokine removal therapy. And this is something, if you copy this link, I don't want to click on it, you can watch this TV interview with Dr. Durham from the Medical College of Wisconsin. And their results went on live in an American TV channel because they treated 3 patients who were about to die with severe, the sickest patients, COVID-19 related respiratory failure. They were put on ECMO and at the same time on Cytosorb, and they had such good experiences that they were broadcasted on TV. And this was one of the results why, or at least that was parallel with that the FDA, and I will get back to this, gave emergency use application for Cytosorb in COVID-19 patients with severe respiratory failure. This is a very recent paper just to emphasize how useful Cytosorb therapy can be in acute respiratory failure. Akil and co-worker, they compared 13 patients with severe pneumogenic sepsis on ECMO, requiring ECMO treatment. And what you can see here, that in the 13 patients who they treated with ECMO, this is how procalcitonin decrease, very similar to our data I showed you at the beginning, and very dramatic decrease in, sorry, this was procalcitonin, and very dramatic decrease in noradrenaline requirement in these patients. In the control group, and this was a retrospective study, and they did some propensity score matching, they couldn't see this significant change in these patients. And they concluded that in these patients with pneumogenic sepsis requiring ECMO, Cytosorb is an effective therapy. So to sum up, because unfortunately at the moment, we don't really have much more to show in this field of medicine. But what we have is some pathophysiological rationale of potential indications in any hyperinflammatory condition. And I had no time to show you that in viral infections, hyperinflammation is just as common as in bacterial infection or any other hyperinflammatory condition. So when you see a patient with very high need of noradrenaline, with increased capillary permeability, then and the patient is not improving after your standard treatment, then please consider Cytosorb. In patients who are in very severe ARDS and before proning, again, please consider to put in an intravenous access, just in case if you need, you can start some blood purification therapy. And especially patients who are in ARDS, reaching such severity that they need ECMO. And again, why not to put a cartridge in? You may improve patient outcome with this. There is an immense interest in this therapy worldwide. The device received emergency use application approval in the USA. The same happened in India just a week ago. And Cytosorb therapy is in the national guidelines in China, Italy, and Panama. A bit different applications, but more or less it follows the same concept. And this is a data coming from 2 weeks back, but something like 800 patients were treated according to our sales force with Cytosorb all around the world for COVID-19 caused diseases. There's immense research activity also. We have registries, and I just highlighted here 3, and plus this is an observational study. So the Cytosorb International Registry, which is run in Jena, included COVID-19 as an addition to data collection. The risk registry is a registry run from the University of Zurich, from Switzerland, Europe. The Search COVID-19 is a COVID-19 registry designed and run by the University of Page, where I am working at. And CytoAid is a prospective observational study of COVID-19 patients who are treated with Cytosorb. So this is the data collection activity. There are a lot of case reports and series submitted for publications, and there are prospective randomized controlled trials. I just made a screenshot of 3 of those from clinicaltrials.gov. And there are 2 possibilities in approaching this problem of COVID-19 and hyperinflammation and Cytosorb. If you look at the data generated since 2015 to 2019, there is an immense improvement in treatments, publications, and so forth. And my philosophy is that you have two options. You can wait for evidence or join the generous knowledge, because I mean, this improvement, this increase in number of papers, number of studies, number of treatments without any clear-cut evidence and guidelines, I think this deserves an attention and deserves the consideration of every physician and unit who treats critically ill patients with hyperinflammation to consider Cytosorb and generate data. And at this, I stop, and thank you very much for your listening and attending, and I am really happy to answer any questions.
Muchas gracias. Creo que la exposición ha sido bastante elocuente y creo que nos ha quedado a todos muchas inquietudes. Yo le pediría a nuestros médicos, panelistas también, al doctor León, no sé si el doctor Cristian León quisiera hacernos algún comentario respecto a este nuevo tipo de terapia. Cristian.
Ahora sí, ¿me escuchan?
Sí.
Perfecto. Bueno, felicitar al ponente, que como usted bien ha dicho, ha sido una exposición bastante gráfica con los puntos clave. Es evidente que a estas alturas del manejo de esta pandemia y en general sin muchas armas terapéuticas eficazmente probadas, como bien dice el doctor, uno no puede estar ajeno a que estas alternativas que empiezan a aparecer puedan ser tomadas en cuenta como una alternativa para el manejo de pacientes graves. Y yo lo que quiero comentar es que en realidad para nosotros esto no es, digamos, algo tan nuevo. Ya se ha tenido la oportunidad y la experiencia de trabajar con este tipo de terapias extracorpóreas. Hemos juntado una pequeña experiencia de 3 pacientes que hemos utilizado terapias absortivas, justamente con la inquietud de poder ver cómo se comportaba el compromiso inflamatorio de estos pacientes. Y estos pacientes normalmente desarrollaban enfermedades severas inflamatorias como pancreatitis o shock séptico. Y si me permite, la audiencia y usted también, doctor Hidalgo,
Sí, claro.
esto es más o menos algo de nuestra pequeña experiencia con algunos pacientes, por ejemplo, con pacientes con pancreatitis severa en quienes usamos terapias absortivas combinadas obviamente con tratamiento dialítico continuo, con el objetivo de reducir tanto el proceso inflamatorio como el riesgo de muerte de estos pacientes. Yo no puede ver claramente aquí, por ejemplo, que al día 5 de terapia absortiva más diálisis continua, hay una caída dramática de la interleuquina 6, de la amilasa pancreática y de la lipasa, ¿no? Entonces, pancreatitis severa es una de las indicaciones que nosotros hemos tomado en cuenta para el uso de esta terapia. Igual para pacientes posoperados cardíacos, donde podemos ver que en cierta manera hemos juntado esta experiencia mostrando cómo descienden los niveles de PCR también de forma dramática, siendo en cuenta que es a veces difícil en nuestro medio dosar otros marcadores inflamatorios como interleuquina 6, pero aquí también tenemos otro caso de un paciente con pancreatitis y falla hepática, donde hemos también podido utilizar este tipo de terapia y se ha podido observar claramente cómo hay un descenso significativo de interleuquina 6 y de las bilirrubinas, ¿no? Ya en otros momentos se ha utilizado también diálisis hepática como una alternativa a las terapias dialíticas convencionales. Y claro, nuestra experiencia está vinculada principalmente a aquellos pacientes inflamados pero con falla renal, ¿no? Creo que la novedad y en cierta manera la experiencia que hay que empezar a trabajar desde ahora es en aquellos pacientes básicamente con distrés respiratorio agudo, con necesidad de soporte ventilatorio con parámetros muy altos, y seguramente eso lo comentará el doctor Castillo, y en pacientes también sobrehidratados, ¿no? Pero en cierta forma, repito, no es algo ajeno a nuestro medio, ya se ha hecho, ya lo hemos podido hacer y de hecho que hemos visto los resultados de una manera bastante significativa.
Gracias, Cristian. Doctor Castillo, quería saber un poco su opinión y lo voy a llevar a una pregunta que después vamos a trasladársela al profesor Monar. Es el detalle de cuándo es el mejor momento de iniciar este tratamiento, antes de ventilación mecánica, durante ventilación mecánica o cuando nuestro paciente esté en el momento del distrés o la disfunción severa. Doctor Castillo. Lucho. Profesor, yo quisiera trasladarle la pregunta que le está diciendo el doctor Castillo, no tenemos todavía comunicación, es el mejor momento de utilizar este tipo de terapia en nuestros pacientes. Y la segunda pregunta es, ¿cuál considera usted que son los efectos secundarios o los problemas que podríamos tener en el camino?
These are the most important questions. And one time, so there are two possibilities. The first one is easy. It's when there is hyperinflammation. When you have a patient who requires high dose of noradrenaline, you've done everything, you have already done invasive hemodynamic monitoring, fluid resuscitation is over, all your basic resuscitation measures have been fulfilled, and your patient is not improving, the noradrenaline is going up, you have to give another vasopressor, the patient is not improving, but you see that this patient has a chance to survive. And this is when you can consider that this patient needs some adjunctive therapy. And by removing the cytokines at this stage, you may help the patient by stabilizing him or her hemodynamically. And then you give a better chance for survival. So, but this is kind of, it's easy to define. The other indication, which was possibly even more important in your question, early indication, before actually the patient goes into dire straits. Now, to define this moment, this is extremely difficult. And I've been giving lectures, and I've done a lot of research in hemodynamic stabilization and ARDS and so on. And usually I conclude my presentation when I talk about lung recruitment, hemodynamic stabilization, that what we need on the intensive care are well-trained, experienced, devoted doctors who can make these decisions, who can realize that this patient is just not following the trajectory I would like him or her to follow. And then you have the nose to detect that the patient is not going the right way. So I am going to start something plus some adjunctive therapy right now. Obviously, it would be very nice to develop scores. And let me give you two examples. One is from Brescia, from Italy. And they have submitted, well, I'm not sure about the city, it may be Bergamo, I'm sorry about this, I do apologize. But anyway, there is one study group from Italy, and they submitted a protocol for ethics approval in which they want to start Cytosorb based on their experience with these patients before they actually get into severe ARDS, never mind ECMO. And when they are in a moderate as defined by the Berlin definition, moderate ARDS condition. They do not want to improve, and then they start Cytosorb early. And the endpoint is whether these patients will end up on ECMO or not. So there are centers who used Cytosorb during the COVID-19 epidemic, and they experienced that the sooner they started, the better the outcome was. However, obviously, we don't have any objective help at the moment. So what we need really is to analyze the prospectively collected data all over the world and to find those combination of parameters, including physiological data, laboratory data. When we put that in together, and then we design some kind of a scoring system, which gives us an indication that these patients can progress into multiple organ dysfunction, severe ARDS requiring ECMO with a very high percentage of likelihood ratio, and then start Cytosorb at that time.
Muchas gracias por la respuesta. Me parece que el doctor Castillo ya se ha conectado. Doctor Castillo, ¿quisiera darnos alguna opinión al respecto en su experiencia en cuidados intensivos?
No sé si puedo hacer alguna pregunta al doctor
claro.
Molnar.
Sí.
Doctor Molnar, a pesar de que, como usted dice, son series de casos o pequeñas experiencias recopiladas a lo largo del mundo, ¿cuál cree que es la principal razón para que este tipo de terapias, dada su eficacia bastante aparente, no se haya generalizado en economías mucho más fuertes y poderosas y con mayor acceso a esta tecnología como en Estados Unidos o también la misma Europa, ¿no? ¿Cuál cree a su criterio que es la principal causa por la que esta terapia aún no alcanza a ser una alternativa de inicio para estos pacientes, ¿no? Pacientes inflamados con infección por coronavirus?
It's a very good question, but very difficult to answer. I don't know the answer, to be honest. I don't know the answer. All I know is that there is a big noise around the device. In fact, the demand is so big at the moment that the company finds it quite difficult to catch up with the demand. So physicians who are trying it and they use it at the bedside in patients, they become very enthusiastic about it. Well, at least most of them. And the demand has really increased over the last 2 months immensely. So, and this is a story. I joined Cytosorb in September last year. And I started using Cytosorb as a head of the ICU and head of the department in a Hungarian university hospital in 2014, 2015, something like that. And I initially started using it as a research tool because I was interested. I've been involved in biomarker research and inflammation research for 25 years. And my physicians, when they saw the result, when they saw the progress of the patients, they demanded to use it in outside the study criteria. So this is the only reason why there are more than 80,000 treatments now in the world, because those who start using it, they see that those patients who they think that there's nothing more they can do, they start the treatment and the noradrenaline is coming down, a lot of parameters improve. And And this is the only explanation why the treatment and the interest is going up. Why it is not included in guidelines, and possibly this was your other question, that how come that there is a pathophysiological rationale? So why? Because there is no clinical evidence. And if you think back of the Xigris era, do you remember that, Dr. Leon? The activated protein C story in 2001, whatever. And this was, I don't know if you in Peru used Xigris or not. I used Xigris in my department at that time. I mean, the number of Xigris I added to patients, or the number of patients treated with Xigris at that time, were double of all of the patients treated in Hungary. And we had very positive experience with this. We could see patients improving. Of course, we lost a lot of patients because these were non-responders or hopeless or whatever. So I still believe that Xigris was a good drug. And after this came all the restrictions and the company, the doctors' involvement in industry kind of thing. So what I sense now that physicians who are really key opinion leaders around the world, they are very, very cautious to take sides beside a treatment that has not been proven by large randomized trials. And the authorities are very cautious as well. So we are, it's really down to us physicians working at the bedside on the ICU to generate the evidence and to test the device, to test the pathophysiological rationale. And you know, I was involved in hemodynamic monitoring for decades, and I remember chairing sessions, giving lectures on cardiac output monitoring and all the rest of it. And there are believers and non-believers, and I mean, my approach has always been that, okay, I know that it doesn't improve outcome, but if I have a question, what is the cardiac output of this patient? And I want to measure that continuously. Give me another device, or give me, but I need that value, because within oxygen delivery equation, cardiac output is the most important parameter. The other one is arterial oxygen content. And I need to know these parameters to treat my patients appropriately. So, you know, it's sorry if I went on for too long, but this is a very complicated process. Why Cytosorb and these adjunctive therapies are not involved in guidelines as recommendations. And undoubtedly, we need prospective randomized trials to show it, undoubtedly. But on the other hand, anything that has strong pathophysiological rationale, and this has been my approach to these patients, at least I would like to try certain things.
Profesor Molnar, estos pacientes que nosotros manejamos reciben otros tipos de tratamiento. Algunos les damos terapia antileuquina 6, a otros les damos antibióticos. La pregunta es, ¿y el aclaramiento de estas otras sustancias con este tipo de terapia no podría ser contraproducente?
Dr. Hidalgo, excellent question. And this is, I really, I mean, I am not at the bedside now for a couple of months because I am working in a translational medicine department. I'm guiding research. But it is really surprising to me that this IL-6, anti-IL-6 treatment went into the COVID treatment like evidence. And it's really funny because, as I showed you in my presentation, for me, and I've been researching this for inflammation for 25 years, it doesn't really make sense just to attack in this severe condition one single biomarker, which is IL-6. How do you know that just kicking this out from the game, is it good or bad for our patients? And the data, what is coming out now, is very controversial as well. And we don't have any prospective randomized trial to show whether anti-IL-6 tocilizumab works or not. It is an expensive drug as well. And even the guidelines, the Surviving Sepsis Campaign guideline adapted to COVID-19 clearly indicate they do not recommend to use it. They do not recommend to use antivirals. And when I read the papers of case reports, everybody reports that, oh yes, they gave chloroquine, they gave tocilizumab. So really, I can see that physicians are desperate. They desperately try to help their patients, which is good. And at the moment, my answer is that I don't see the pathophysiological rationale. Every single monoclonal antibody therapy failed in critical care. Every single one of them over the last 30 years. So why do we think that this one will work? Because it works in the HLH patients, and hemophagocytic lymphocytosis patients, which is a very small cohort of patients. So it is a very interesting topic, and we physicians sometimes really make decisions. You know, I would try to give everything to my patients what I have, and if there is any small rationale, then let's do it. But you may do harm. Antibiotics, again, this is one of my main issue, and I think that in intensive care, in medicine, we've done a lot of wrong things with antibiotics. We doctors started from the general practitioners in cities, villages, and towns, ending up with intensive care physicians. We've been giving antibiotics to our patients in a totally uncontrolled manner for everything. And in my view, antibiotics are nothing more adjunctive therapy. Because if antibiotics would be the remedy for bacterial infection, the humanity would be dead by now. But the humanity survived for hundreds and thousands and million years without antibiotics. It is an adjunctive therapy. It can be very useful. It can hasten recovery if we use it appropriately. But we give empirical antibiotics to every patient who has temperature, who has high leukocyte count, CRP, whatever. And this is what was the result of this: Clostridium difficile, multi-resistant drug strains, and you can go on with this list. So we do harm to our patients by giving antibiotics. And even I disagree with the Surviving Sepsis Campaign guideline that they recommend to give antibiotics to COVID-19 patients who need mechanical ventilation. There is no evidence whatsoever. At least they say it is weak recommendation and no evidence, basically. So this is my experience, and we've done a lot of research on procalcitonin kinetics to assess how can procalcitonin help us with defining, diagnosing infection and defining whether or not we are giving appropriate antibiotics. So this is, again, something you asked that is very close to my research interest.
Ahí tenemos una pregunta del panel. Nos comentan que la FDA aprobó el tratamiento con Cytosorb en pacientes con injuria pulmonar aguda temprana como distrés respiratorio temprano en pacientes que ingresan a UCI, pero aún no tienen indicación de ventilación mecánica. Y vuelven a hacer lo que yo ya les había preguntado, si se está utilizando esta indicación.
I'm sorry, Sydney, can you just wrap up a little bit what this question was about?
Ok. Hay una pregunta del público en la que nos comentan que la FDA aprobó el tratamiento con Cytosorb en pacientes con injuria pulmonar aguda temprana, así como distrés respiratorio temprano, en pacientes que ingresan a UCI, pero que aún no tienen indicación de ventilación mecánica. La pregunta es si se está utilizando en esta indicación.
Yeah, well, I must say I don't have the FDA's emergency use application wording in my head. So I cannot make a comment on this. But I know from our US team, from the leaders in the US team, that the major interest in Cytosorb in these patients in the US is patients who are admitted with COVID-19, develop ARDS, and require ECMO. And now the most centers which use Cytosorb, and this is, I may be wrong, but this is what I gathered from our meetings, when the patient has to go on ECMO, they add Cytosorb immediately. In those centers which are willing to try Cytosorb. And this is what the slide I showed you, and I'm very happy to share with you my slides. So Felix, Felix Austin, who is responsible for this region of the world within our group, I'm very happy you have my slides, by the way, so I'm very happy you can share it, you can use it. And on this slide, on which you see the American TV program discussing Cytosorb use in these patients, there is a link. You click on the link, and then you can listen to Dr. Durham, and he treated his team treated 3 patients on ECMO, and they had a huge success. So this is what I can add to this American FDA emergency use approval thing.
Quisiera trasladar al público y a la mesa, si alguien desea hacer alguna pregunta o comentario de cierre, por favor.
Una pregunta. Uno de los grandes problemas que ha tenido nuestro país para implementar tratamientos alternativos, digamos, en lo que se refiere a terapias de reemplazo renal, el Estado restringe a terapias básicamente de baja eficiencia y de bajo flujo. Es muy poco lo que en los hospitales estatales se hace de terapias continuas, de hemofiltración o de hemodiafiltración. La pregunta es, en términos de costos, ¿qué tendríamos que hacer para que este tratamiento pueda ser accesible, considerando que nuestro gobierno en cierta manera restringe terapias no convencionales justamente por el elevado costo y tiene que pasar una serie de capas burocráticas para poder hacerse o poder realizarse? ¿Qué podríamos hacer para abaratar costos en este sentido? Y volverlo una terapia accesible, claro está, ¿no?
Yeah. Well, as you know, I was head of department, head of the ICU for 20 years. So this is a story of my life, what you have just asked. And well, on the short term, you need a very skillful head nurse who can balance the economic figures and the finance in a way that you can squeeze in a few cartridges. And this is what we did basically in my department. But this is just my practical approach. On the long run, we've been working very hard to produce data. And we have a very active and talented team. One in the Cytosorb company. These are health economists, very talented guys, girls and boys, and they do meta-analysis and financial analysis on outcomes and we have a very active meta-analysis and also economic group at the University of Page. I forgot to tell you that I have 3 affiliations at the moment. It's one of them is Cytosorb, where I'm a medical director. The other one, I'm a professor in the translational medicine department, and I'm also a professor in a Polish academic intensive care department. So, and in the Page unit, we also have a very active group. So now we've been working very hard to produce data, meta-analysis, systematic reviews, cost analysis, to show that if you fasten shock reversal, if you improve shock reversal, you shorten the time the patient is in shock, it may have an effect on outcome like mortality. So we've been doing a lot of work, and we do hope that this will result in significant publications. And then you can go to your hospital administrator and say that, listen, we have some data that if we get this patient out from dire straits as quickly as possible, for example, with the addition of Cytosorb, you may reduce costs, you may improve outcome, or vice versa. You know, the two goes together. If the patient is short, it stays shorter in the ICU, shorter in the hospital, and never mind survival. So you know, it can be cost effective. But at the moment, we don't have data. We've been working on it. So let's hope that we can generate this within the next year or so.
Profesor Monardo, creo que ha sido una actividad muy interesante. Nos da una perspectiva de decisiones de tratamiento diferentes de nuestros esquemas habituales. Es un reto decidir un esquema de tratamiento que todavía no tenemos estudios largos que definan si es válido o no, pero la lógica, como lo ha planteado usted, nos demuestra que es una alternativa sumamente interesante y que la debemos de tener en cuenta dentro de la parte de nuestras estrategias de manejo. Yo creo que dado el avance del tiempo y la experiencia, ha sido una muy bonita webinar, una muy bonita experiencia para todos los que hemos podido tener contacto con esto. Muchas gracias a todos los ponentes, muchas gracias, profesor, por su tiempo. Estamos en contacto.
It's been a pleasure. Thank you very much, and wish you all the best. Stay safe, and I hope to see you soon in person.
Será un placer. Cuídese mucho.